Hi, my name is Dr. Trilokesh Kidambi, and I'm a gastroenterologist at the City of Hope Medical Center in Duarte, California. I'm assistant clinical professor and I'm the director of the colon cancer screening program. And it's an absolute privilege to have this opportunity to give a talk on a topic that's near and dear to my heart, a focus of what I do on a daily basis, and that's colorectal cancer screening and prevention, what we should all know to protect our gut. Before we get started, I wanted to thank the organizers of this talk for inviting me, as well as City of Hope for this opportunity, and within City of Hope, Doug Nyland in particular, for thinking of me and for making this happen. So thank you. I have nothing to disclose. In terms of an overview of the talk, I'm going to start by talking about colorectal cancer statistics and have a few real-life cases to illustrate what we're talking about. I will address early onset colon cancer, which you may have been reading about or hearing about in the news. We'll address methods to prevent colon cancer, such as diet, supplements, and medicines, the different ways to screen for colon cancer, and then, of course, questions. And at that point, I'll actually be jumping on live to take any questions that may come up. So in terms of colorectal cancer facts, colorectal cancer is a term used for cancer that starts in the colon or the rectum. And the rectum is just by convention the last part of the colon, the part near the anus where stool comes out. It's very common. So 1 in 20 people in the United States will be diagnosed with colon cancer. It's the third most common cancer diagnosed in both men and women in the United States. It doesn't favor men or women. It affects them both equally. And there are currently more than 1 million colorectal cancer survivors in the United States. There are some symptoms of colon cancer. Those include things like blood in the stool, like cramping or abdominal pain, weakness and fatigue, unintended weight loss, a change in bowel habits. You may have heard of the term pencil thin stools, constipation, diarrhea that can last for more than a few days. And while these are definitely things that would make us concerned about these symptoms would definitely make us concerned about colon cancer, unfortunately, in the vast majority of patients, they actually have no symptoms when they're diagnosed with colon cancer. As a result of that, many of the symptoms actually occur as the cancer progresses in stage, meaning that it's spread beyond just the colon, whether that's to local areas, local lymph nodes, or it's metastasized or spread to a different organ. Who's at risk of colon cancer? Well, as I said, both men and women are at risk. Researchers have found several risk factors that may increase a person's chance of developing colorectal cancer, such as a patient's diet, whether or not they're obese, they smoke, their ethnicity, and family history. However, of all these things, age is the most important risk factor. As you age, your risk of colon cancer increases. And so that's a risk factor that's obvious. I'm going to start by just talking about a few cases from this past year during the pandemic to highlight colon cancer. So the first one is a man that was in his late 60s with no major medical problems. He was very healthy. He was jogging 2 to 3 miles per day. He continued to work full time. He loved his job. And he was referred to me by his primary care doctor after labs showed that he had low blood counts, what we call anemia. And along with that, as a part of the evaluation for anemia, it was found that he had low iron levels. His blood counts were normal 1 year prior, so this was a new change. His annual checkups up to this point had always been normal, including checks of cholesterol, diet, and exercise. Cholesterol was under control with diet and exercise, and he had an annual prostate check with both the digital rectal examination as well as PSA values that were normal. He had never had a colonoscopy, though, because he had heard that the bowel preparation was miserable, and the thought of the procedure itself terrified him. So I explained to him that we had to perform both a colonoscopy and an upper endoscopy through the mouth to look in the stomach to look for a reason his iron levels were low. He continued to refuse. So I had to call his wife during the office visit, and we got him scheduled for the same week for the procedure. And unfortunately, what I found, and it's highlighted with these green arrows, the green arrows are pointing to a big excavating ulcerated mass lesion, which unfortunately turned out to be a colon cancer. It was the cause of his anemia. It was slowly bleeding, not to the point that he could see blood in his stool, but to the point that his blood counts were falling. So I biopsied it during his colonoscopy. And before he left our procedure suite, we got lab work done to look for tumor markers. And we had him set up for a CAT scan the following day to look for whether or not the cancer had spread. Fortunately, his CAT scan did not show spread. It showed that it was a localized colon cancer that we found relatively early. And he was able to see one of my colorectal surgery partners at City of Hope, one of my colleagues who was able to do surgery on him within the month. The surgery went successfully. The whole cancer was removed, and I've done his 6-month colonoscopy after the surgery, and everything's all clear. So I'll be seeing him back in roughly a year, and we're really hopeful that he's cured of his colon cancer because we found it early. The second example is a patient that I wanted to bring up just because of the pandemic and patients that are sort of, I wouldn't say ignoring symptoms, but are doing their best to avoid coming in to be seen because of the concerns about, transmission of COVID. So this was a woman in her mid 40s who self-referred herself to me after noticing blood in her stool off and on for several months. She was working from home and had noticed it, but was hopeful, that it would sort of pass. She had spoken to her primary care doctor, who told her it was probably hemorrhoids, but that if it persisted, to go ahead and get checked up. When she saw me, we checked blood work. That was normal. She had no family history of colon cancer, but because the symptoms had persisted, I did recommend a colonoscopy. This is just a piece of information that we've been doing colonoscopies at City of Hope throughout the pandemic. As you can imagine, with most of our patients having cancer diagnoses, we haven't had the ability to sort of slow down all too much because our patients are in need of care that really couldn't stop for the pandemic. So in any case, we did the procedure safely. And I found two things. The first on this slide is a very flat and subtle polyp. The left side shows the polyp under normal light, what we call white light endoscopy, and the green arrows are pointing towards this flat polyp. And on the right side, it's the same picture, but we have a filter on our camera that really highlights the blue and green light spectrums, green and red light spectrum, sorry, what's called narrowband imaging. And you can see that there's an irregularity there. So I was able to remove this polyp during the colonoscopy using a technique called endoscopic mucosal resection, where I was able to cut it out completely without doing any surgery. And I also found another polyp. This is a different polyp. It looks almost like a cauliflower, a big polyp with a stalk that actually, as I saw it during the procedure, was intermittently bleeding. And so this was the source of a rectal bleeding. I was also able to cut this polyp out during the colonoscopy itself. The pathologist called me with the biopsy results within a few days. That flat polyp was what we call a sessile serrated adenoma with dysplasia. That's a type of precancerous polyp with high cancer risk if left in the colon that I was able to remove completely. And that cauliflower-looking polyp was a tubulovillous adenoma with the focus of adenocarcinoma, which is the medical term for cancer in situ, meaning that it was a precancerous polyp with a small area that had developed into cancer. Fortunately, the margins of both polyps were normal, indicating that I removed them both completely. She went home after the procedure uneventfully, and she's been doing great. I'll be seeing her back in a year to confirm she doesn't have any new polyps. So that last case was in a young woman, and it's a nice sort of segue into a discussion about early onset colon cancer, which you all may have heard about if you're reading the news or on the news on the TV. And so what that refers to is cancer developing in patients under the age of 50. We know that since 1994, there's been an increased onset of cases of this. It's increased by 51%, according to the National Cancer Institute. In the United States, 11% of colon cancer diagnoses and 18% of rectal cancer diagnoses occur in individuals under the age of 50. And we anticipate this is going to increase significantly in the next 10 years. And so this rising incidence in young onset colon cancer has led both the American Cancer Society and more recently the US Preventative Task Force to recommend screening from the age of 45 rather than 50, which is something that had been recommended previously. One of the things that's a natural question that comes up is whether there's ways to prevent colon cancer with things like medications and supplements. And several studies have looked at whether supplements like vitamins, antioxidants, or medicines, some of those are listed here, as well as diet, can prevent the development of colon cancer. As you can imagine, these studies are really hard to do, and they take a long time to do because there's a long dwell time for cancer development, and also because it's really hard to parse out the effect of environment or other factors that may lead to cancer development. But what we do know, in short, is that people who take a baby aspirin have a lower chance of developing colon cancer. The important thing to note there, though, is that the studies that have been done on this were not done to prevent colon cancer. They were observational. So they were studies looking at patients that were on aspirin to prevent stroke or heart attack. And we found that in those patients that were prescribed aspirin compared to those who were not, there was a lower rate of cancer, colon cancer. So what I tell people is you don't start aspirin just for the sake of colon cancer reduction, because there is a risk of bleeding, but to discuss that, whether or not there's another reason to be on it with your primary care doctor. We know that diets high in magnesium, and some of the foods, healthy foods are listed there, reduces the risk slightly. We know that high fiber diets reduce the risk. And we know that certain vitamins like vitamins A, B, and C supplements, garlic, omega-3, they don't actually lower your risk. So I would tell you to save your money on purchasing those. We know that high amounts of red meat consumption, smoking, and alcohol all increase the risk, but caffeine does not lower the risk, sorry. Because the coffee debate always goes sort of back and forth if you follow the news. The last thing I wanted to sort of talk about as it relates to this is an emerging topic, which is the gut microbiome, or the bacteria in your gut. We know that the bacterial makeup of the gut, what we call the microbiome, is probably a player in the interaction between your environment, so the foods you eat, whether or not you have toxic exposure like smoking, and your body, in your human body. And the composition of the gut microbiome is determined by things like diet, lifestyle, and antibiotic exposure. You could think of it as the environment in which the food and body interact, and that helps you conceptualize why it might be important. The picture on the left sort of shows that idea that you have diet, you have your gut microbiome, and you have your host, the human being, and how those things interact either can lead to cancer development or prevent it. And on the right, again, not meant to be a quiz or overly complicated, but it just shows some of the mechanisms by which we think these interactions occur. So in the context of red and processed meat, you can see some of the breakdown products as your body breaks it down, how that interacts with bacteria, and how that can lead to things like oxidative stress, gut barrier function being decreased, cell proliferation that can lead to colon cancer. So this is still an emerging topic. We don't exactly know how this is going to play out, but we know that it's probably a player in both colon cancer and other cancers. Patients always ask me to summarize, what do you recommend, Dr. Kidambi? What is your approach? What would you tell me to do? What can I do? What's under my control? And so I tell them that a Mediterranean diet, a diet that's high in fruits, vegetables, and whole grains, is generally a good idea. In this diet, fish and white meats are the preferred protein choices over pork and other red meats. I tell people to consider adopting a plant-based diet, whether that's all the time or a few days a week. And what I mean by that is a diet that has a lot of colors, like beautiful, red from beets, orange from carrots, to really try and mix it up and get all the beautiful colors that are available in plants. I tell people not to peel their fruits and vegetables, to mix it up with both raw and cooked leafy greens, and then to consider experimenting with different cuisines and spices as a way to sort of get different fruits, vegetables, and spices into the diet. I believe that moderation is really important. Too much of anything or avoidance completely of things can be really hard to follow. I recommend limiting refined sugars and processed foods. I recommend a serving of probiotics per day. I've listed a bunch of them. You can go to Sprouts, Whole Foods, Trader Joe's, and they have all sorts of different interesting probiotics in food. And then I have just a few simple rules about food, and that's that they should be naturally occurring colors and ingredients you can pronounce. So those sort of neon green or weird peach colored Yoplait yogurts are not a good idea. Plain yogurt and adding your own sort of natural sugars, whether that's fruits or agave or whatever, is a good idea. Last part of the talk is really just about ways to screen for colon cancer. Screening means average risk. So this means you don't have any concerning signs or symptoms. We're talking about adults between the ages of 45 and 75. And once you hit 76, if you've never had polyps on a colonoscopy, the risk of developing a polyp through the rest of your life or cancer is considered low. So we don't recommend ongoing screening. Patients with a family history of colon cancer may need to start screening earlier. It depends on the exact circumstance. So that's something you should discuss with your doctor. And then the real important point here is that if you have symptoms, irrespective of your age or colonoscopy results, you need to be evaluated by a doctor because it could be the sign of something more concerning. And the idea behind colon cancer screening is twofold. The first is by identifying a cancer early, like in that first patient we discussed, you can potentially have curative treatment. And the second point is that if you can identify and remove a precancerous polyp before it turns into cancer, like in that second patient, you can prevent the cancer from developing. And so that's been the success behind colon cancer screening. There's different ways to screen for colon cancer. In the US, colonoscopy is the most common, which of course requires the dreaded bowel preparation and is a medical procedure, but it's considered the gold standard because you can both identify and remove at the same time. But there's stool-based tests like the FIT or Cologuard, where we examine the stool for presence of blood or tumor DNA. There's also a non-invasive CT scan called a CT colonography. The key point from this, though, that I want to make is that a positive stool-based test or a positive CT scan does not mean that you have colon cancer. It just means you need to be screened for colon cancer with a colonoscopy. And so you don't need to take that positive as a sign that you necessarily have it. You just have to follow up and get your colonoscopy. I'm going to stop there. Information about our City of Hope gastroenterology program is provided in that link. And if you're interested in becoming a patient at City of Hope, we have the information on how to sort of call and get set up. But I'm going to open myself up for questions.
Okay, I think one of the questions that came up during our earlier discussion you answered in your presentation as to when you should stop having colonoscopies.
Yeah, so the answer is generally speaking 75, and that's if you've been up to date with your colon cancer screening up to that point, and it's always been negative. So if you had your colonoscopy at 50 and 60 and 70, they were all normal, then you don't need to have one after 75. The situation changes if you've had polyps before. You may or may not need to have to continue to have them. It depends on the size, the number, and the type of polyps that you've had prior to that. And of course, if you're 76 with normal colonoscopies before, but now you developed rectal bleeding, then you need to be evaluated.
Is it possible? Oh, okay, I was just going to say, let's stop sharing.
Yeah.
Okay, other questions, people?